everyone for making it online to celebrate International Human Rights Day today. I'm Helen Watchirs, the President and Human Rights Commission, on behalf of the ACT Human Rights Commission, and my colleague co-chair, Karen Toohey, sitting next to me, who's the Discrimination, Health, Disability and Community Services Commissioner. We also have Heidi Yates and Jodie Griffiths-Cook, our colleague commissioners, in the audience today. Our topic today is the COVID pandemic, the right to health, COVID and pandemic responses. COVID has opened up fault lines in our society. It's aggravated social and economic deprivations and exposed health inequalities. The impact has been experienced disproportionately by vulnerable populations throughout the world, including here in the ACT and probably more graphically in Melbourne, given the concentration there and the images of what happened in public housing towers to poor populations are still seared in our memory, I think. I'd now like to invite Selena Walker to perform a Welcome to Country. Thank you, Selena.
Thank you. Yuma, Galaganya Jelena Walker, Darawa Nuna Darawa Nunawo. Hello, my name is Selena Walker. This is Ngunnawal Country. Thank you for inviting me here to do your Welcome to Country for this very important event. I want to start by first acknowledging my elders, the Ngunnawal elders, past, present and emerging, and extend that to all your elders, whichever country you are joining us from. I want to acknowledge any other Aboriginal and Torres Strait Islander people that have joined us. Welcome my brothers, sisters, aunts and uncles. And want to acknowledge the minister that's joined us, or trying to join us. 2020 problems, hey? Thank you for putting this together. Well done to the Human Rights Commission. And yeah, I'm privileged to be involved in this. The Ngunnawal community are the traditional custodians of Canberra and the region. You may not be aware that the Ngunnawal Nation is made up of several family groups and not just individuals who represent this country. Therefore, as a community, we have an elected body known as the United Ngunnawal Elders Council to represent us, along with the Aboriginal and Torres Strait Islander elected body of the ACT. This is important for you to understand and acknowledge, for our identity is a collective identity. There are other Indigenous and non-Indigenous people from around the nation, the country and the world who've come to live on Ngunnawal land. I would like to acknowledge and welcome you all. The tradition of welcoming the people to country is a practice that was handed down by our ancestors, elders and elders from the beginning of time. Before entering another person's country, you would first announce your arrival and not enter until the traditional owner formally welcomed you. The reason for this practice was to protect your spirit whilst in another person's country, and also to show respect for the country which you are entering. It's wonderful to see this practice is now recognised and respected. I suppose it's not like entering into someone's home unless you're first invited. The Ngunnawal people, as within all Aboriginal people, have a great heritage that we would like to share with all Australians from every walk of life. As you are aware, Canberra means meeting place, and Canberra has been a place of gathering for many Aboriginal tribes of Australia to come together to deal with important business and also for ceremonial purposes. Our Ngunnawal ancestors believed in the importance of people gathering to build relationships, share knowledge, and to celebrate the gift of heritage and history. We believe it's important for all to recognise our unique history and to gain an understanding that our land is our heritage and how loss of land has disconnected so many Aboriginal people from their spiritual links, cultural heritage, and identity. So on behalf of the Ngunnawal people, thank you very much. I can't stay for the rest of the event. Unfortunately, I've got tribal kids that I need to look after. So I do wish you well. Well done once again. And I'll now finish in the words of my people, the Ngunnawal people. Yumalandi Yunanga Yarabu Yangu, which means you may leave footprints on our land, or in other words, welcome to country. Thanks very much. Enjoy the rest of the event.
Thank you so much, Selena, for your very warm words. I too would like to acknowledge the traditional custodians of the land on which we meet, the Ngunnawal people. I respect their continuing culture, the oldest in the world at over 65,000 years and protected under the Human Rights Act. I'd like to acknowledge the attendance of other Aboriginal Torres Strait Islander people who are attending today's community forum, such as Karl Briscoe, and I'd like to acknowledge the attendance of my colleagues from JAX, Richard Glenn, Jennifer McNeil, John Peach, the Coordinator General of COVID, Rebecca Cross, David Price from Access Canberra, CEOs John Borsig from Legal Aid and Francis Crimmins from YWCA. And I hope that we now have the new Minister for Human Rights, Tara Cheyne,
All good, bye.
In COVID times, human rights are more important than ever that no one is left behind, including Aboriginal people, particularly given the closing the gap targets, people with disability, older people, and the Royal Commissions into both those vulnerable populations have shown that COVID can have a very potent influence here and overseas. So it's important to know that. I'd now like to invite new Minister for Human Rights, Cheyne, to open this community forum. Thank you, Minister.
I am just having a little bit of trouble. You might notice I'm lagging. Just a minute.
We have 4 panellists here today. Professor Andrew Byrnes from the University of New South Wales, Emma Campbell, the CEO of ACT Council of Social Services, Karl Briscoe, the CEO of National Association of Aboriginal Torres Strait Islander Health Workers and Practitioners, and Darlene Cox, the Executive Director of Healthcare Consumers Association. And the panel will take place after the opening by the Minister.
Can everybody hear me now?
Yes.
Yes. Good to
Yes.
go, Minister.
Thank you, everybody. I'm very sorry about that. Thank you. And thank you for your patience. I do apologise. Sometimes WebEx does seem to throw up some gremlins, and today I was subject to that. And I did just catch the end of Selena's welcome to country, and I would also just like to acknowledge the traditional custodians of the land that we're meeting on, the Ngunnawal people, and pay my respects to their elders past, present and emerging, and also to acknowledge Selena, Karl and any other Aboriginal and Torres Strait Islander people joining us for this International Human Rights Day forum today. Human rights have particular significance for Aboriginal and Torres Strait Islander peoples who for so long were denied basic rights to be treated equally in this country. And I'm very pleased that our Human Rights Act recognises the distinct cultural rights of Aboriginal and Torres Strait Islander peoples in the ACT and the importance of maintaining culture and connection to land, water and resources. I am really honoured and also really quite humbled to be the first ACT Minister for Human Rights. And I am very excited to be here with you, finally, to celebrate International Human Rights Day. I am very proud, of course, that the ACT was the first state or territory in Australia to adopt a legislative charter of human rights. And I'm proud that we continue to lead the way through the careful but still consistent expansion of that protection to include additional rights, such as Aboriginal and Torres Strait Islander cultural rights, the right to education, and of course, most recently, the right to work, which was led by my former colleague, Ms. Beck-Cody. The government has committed in the Parliamentary and Governing Agreement to explore the addition of the right to a healthy environment to the Human Rights Act in this term. And it makes sense, of course, and Aboriginal and Torres Strait Islander peoples have always known that our environment and the way that we care for it is inextricably linked to, and indeed a key determinant of, our health and well-being, both as individuals and as a community. We saw this very starkly with the bushfires earlier this year, reflecting rapid climate change and then affecting the very air that we and our family and friends were breathing. I look forward to the work that we'll undertake in exploring this over the coming term. And of course, related is the pandemic, and I am really pleased that this forum is today explicitly considering COVID-19 through a human rights lens. It's obviously an international issue, but also, of course, a very human experience, and one where fast decisions have had to be made. And that's really thrown up some very important and very real issues, and ones that I think are still being contended with right across the world, especially what happens when these quick decisions have been made in jurisdictions without a human rights lens or without a human rights framework. Finally, another rights issue that I think is well known, that I'm personally very passionate about, is the right of our territory to democratically develop our own laws, brought home no more plainly than us continuing to be denied, for no good reason, our ability to develop and to decide for ourselves our own laws relating to voluntary assisted dying. Sadly, the continues to prevent the people of the ACT and the Northern Territory from exercising their right to decide the laws that govern them on this most important issue. This is a function, of course, of the Commonwealth prohibition on the ACT introducing laws in the Australian Capital Territory Self-Government Act of 1988. This prohibition was introduced in 1996 as a private member's bill, but as part of moves to override the rights of the Terminally Ill Act 1995, which was passed by the Northern Territory Legislative Assembly, and also then to prevent other territories, us in the ACT, from legislating for voluntary assisted dying, and it still persists today. Voluntary assisted dying raises complex issues, including regarding health, but they are questions that I'm absolutely confident our progressive and our well-educated community would be able to deal with in a really careful and a really thoughtful way, and of course, in a way that respects human rights. People do continue to be shocked to learn that the territories are denied this and that this inequity persists in a country like Australia. In my view, it is a breach of our rights as Australian citizens to be unable to participate in a democratic process regarding an issue that is just so fundamental to our sense of dignity and to our sense of autonomy. While Victoria has a compassionate and well-considered regime and Western Australia has followed suit, families in the ACT are forced to watch their loved ones live out their final days without the choices, respect and dignity offered by these other schemes, simply because we are living in a territory rather than a state. But momentum is building, and as each state legislates for voluntary assisted dying, and it seems that Tasmania will indeed be next, it becomes more and more untenable for this inequity to persist. So in my new role, it is part of my mandate to continue to engage with the Commonwealth Government to seek the repeal of these unjust laws that prohibit the ACT even having the choice about whether or not to introduce laws regarding voluntary assisted dying. The fix is a simple one. It would cost the Commonwealth Government nothing while enhancing democratic equality for all. And that the federal parliament, not just the government, but federal parliamentarians, not all, but most, idly sit by and allow this to persist is also of a deep concern to me. I will continue to fight for the equality of our territory communities to have a say on these issues, as well as looking for opportunities to continue to build and strengthen our protection of human rights in the ACT. And I'm very much looking forward to hearing what our panellists have to say today. And I've already, of course, seen some media releases. I wish you all a very happy International Human Rights Day and look forward very much to what I'm absolutely confident is going to be an interesting and wide-ranging panel discussion of human rights issues by our excellent panel here today. Thank you very much for the opportunity to address you all, and let's get on with it. Thank you for your patience with me too.
Thank you so much, Minister, for those very inspiring words. It is a quick fix for Commonwealth, and look forward to that battle. We're now going to hear from Andrew Byrnes, a Professor of Law at New South Wales. He worked on a project on economic, social and cultural rights at the ANU, looking at the ACT Human Rights Act. He's going to give us some context on the right to health. As the Minister said, the right to a healthy environment is part of the parliamentary agreement to be considered. And in international law, the right to health is the main right that a healthy environment comes under. Over to you. Thank you, Andrew.
Thanks very much, Helen, and good afternoon, everyone. It's a great pleasure to be here with you today, and thanks to Selena for her welcome to country. I'm speaking to you today from the lands of the Gadigal people of the Eora Nation, and I pay my respects to their elders past and present. All of us aspire to good health throughout our lives and to the many benefits that this brings with it in the living of a fulfilling life. At the same time, we recognise that none of us is likely to be in perfect health for all of our lives, and that unfortunately some poor health may be unavoidable, despite our best efforts. The contribution that modern medicine and public health policies have made over the last century around the world has been remarkable, especially for those who live in developed countries. Though we know that even in rich countries like Australia, the benefits of good health and the burdens of poor health are unevenly distributed along lines that reflect and reinforce other forms of social and economic disadvantage. My task today is to provide an overview of the international right to health and its relevance in time of a pandemic, but also in normal times, quotes, as well as to reflect briefly on how and why it might be explicitly incorporated in the ACT Human Rights Act. But firstly, the pandemic and the right to health, that a number of mentions have already been made. The COVID-19 pandemic has highlighted many concerns about the right to health, including discrimination against older persons and persons with disabilities in access to acute medical care, to regular care and support services, and to regular medication. The enormous toll on the right to life, to the physical and mental health of persons living in aged care, and their rights to family life with them and their families. We've seen the increased risks of intimate partner violence faced by women during lockdowns. We've seen the interaction, particularly in Victoria, between homelessness and the right to health, and the steps that governments can take to actually address those problems. We've seen the relationship between poorly paid casual work and the right to health of care workers, the health status of Indigenous people and their rights. And we've seen more generally amongst the population the issue of delays or non-access to regular screening services or medical appointments for many other groups in the population. And of course, the important issue of testing and administration of vaccines. What then is the right to health? The first thing to say about the right to health is that it's not in fact a guaranteed right to be healthy. It is actually, in formal terms, the right to the highest attainable standard of physical and mental health. What governments are obliged to ensure is thus influenced by what is attainable at a given time, in a given community, and possibly for a given individual. And it includes, importantly, both physical and mental health. The primary international source of the right to health is a treaty called the International Covenant on Economic, Social and Cultural Rights, with many of which of you will be familiar with that. It was adopted by the United Nations in 1996 and ratified by Australia at the end of 1975, thus entering into force for Australia in early 1976. So the obligations under the treaty have been binding on Australia for almost 45 years. And these obligations indirectly bind the states and territories because their actions or failures to act are those of Australia on the international plane. There have been other important treaties that have expanded on the Economic Covenant in the context of what the right to health requires, specifically in relation to women, children, persons with disabilities, among others. So let me then turn to the broad outlines of the right as set out in Article 12 of the Economic Covenant. The basic elements of the right to health include the rights to maternal, child and reproductive health, the first. The second, the right to healthy natural and workplace environments, of particular importance, I think, to the current proposals mentioned by the Minister this morning. Thirdly, the right to prevention, treatment and control of diseases, very much in our minds. And fourthly, the right to health facilities, goods and services. The Covenant imposes obligations on countries to themselves respect the right and to take positive steps to ensure its enjoyment. Obvious example, of course, is by funding and providing the healthcare system. But it also requires states to protect individuals against violations of the right by private parties. Example of that, of course, is the requirement to have in place adequate workplace health and safety laws and environmental pollution laws. So health is more than just the absence of disease or access to healthcare and services. Ensuring the right to health has personal, community and environmental dimensions. The UN Committee on Economic, Social and Cultural Rights, the principal expert body that monitors the implementation of the Economic Covenant, has noted that the right must be understood as the right to the enjoyment of a variety of facilities, goods, services, and conditions necessary for the realisation of the right to the highest attainable standard of health. This, of course, extends to what are known as the underlying social determinants of health, that is, the socio-economic factors that are closely related with or contributors to good health. So, realisation of the right to health may involve governments ensuring that individuals have access to primary health care, the community as a whole has access to effective vaccines against contagious diseases, and ensuring that the environments in which people live and work are free from factors that damage their physical or mental health. The right includes a whole range of dimensions, and let me list some. The right to access healthcare services on a non-discriminatory basis. These services include child and maternal health services, sexual and reproductive health information and services, and palliative care services. It includes the freedom to control one's health and body, including the right to be free from torture, from non-consensual medical treatment and experimentation, and from physical and psychological violence in the family, community, and at the hands of the state. It includes the right to have access to adequate nutrition, safe drinking water, and safe sanitation. The right to information about practices that will promote good health, including information about nutritional and foodstuffs. The right to have the proper regulation of drugs, medicines, medical technology, and private and public healthcare service providers. The right to live in an environment free of harmful pollution. The right to participate in health-related decision-making. And finally, the right to have access to effective remedies when there is a violation of the right to health. There are many other dimensions of the right, and also reflected in other rights, economic and social and civil and political. The right to adequate housing, the right to take part in leisure and sporting activities, the right to life, among others. The right to health belongs to a category of human rights which are known as economic, social and cultural rights. I'm sure that's no news to most of you. These include the right to education, to work, to an adequate standard of living, and to social security. And the right to health is closely related to those rights. These rights are commonly seen as being different in important ways from the other main category of human rights, civil and political rights, such as the right to life, freedom of expression, the right to vote. And it's these differences that have led to the rather split arrangement in the ACT Human Rights Act and other human rights acts, in that we had many civil and political rights acts included in 2004, but we've been adding bit by bit the equally important catalogue of economic social rights. And it is taking a while, but it's good to see that there's progress, but we can perhaps pick up the rate of progress. The differences between the two categories of rights are often overstated, but economic and social cultural rights are seen as requiring the allocation of resources to a greater extent than civil and political rights, as not being capable of immediate implementation in most cases, and as rights that courts may not or should not enforce. These perceived differences are reflected in what countries are required to do to give effect to economic social rights. And in countries here, I'm including, of course, the states and territories of Australia. Civil and political rights are in theory required to be implemented immediately, though that's not always possible. Economic and social rights, on the other hand, are required to be implemented progressively. This means that governments, including the ACT government, must take immediate targeted steps to analyse the current situation in relation to implementation and draw up a plan with a timeline that includes a monitoring and evaluation process to measure movement towards the goal of full realisation. Governments have a good deal of discretion in how they go about this, but they must actually move forward in deliberate, tangible and measurable ways. In drawing up their implementation plans, governments must draw on the maximum available resources that they can muster. While international law recognises that resources are not limitless, this is a requirement to do more than say, well, we've allocated this much this year and we'll do what we can with that. Rather, it must involve an exploration of ways of increasing resources, prioritising the use of existing resources across the whole of government, and exploring how to deploy those resources most efficiently. A proper human rights budget impact analysis is one commendable way of doing this. The way in which, for example, the Commonwealth Government has found the necessary additional resources to finance the purchase of COVID-19 vaccines and to support other activities is in many ways an exemplary case of how one might muster the maximum available resources in this context. Despite the broad obligation of progressive realisation, there are nonetheless some immediate obligations for economic and social rights. One of those is to ensure that they're enjoyed without discrimination. So even if a right has not yet been fully implemented, there cannot be discrimination against particular groups in their enjoyment of that right. If there is, the priority must be to eliminate that discrimination. The Economic Covenant, like other international treaties and indeed the Human Rights Act, prohibits discrimination on many grounds, including race, colour, sex, religion, national or social origin, property, and other status. That list is now understood as also including categories such as disability, LGBTIQ status, age, and other characteristics. International law does recognise that there may be periods of economic crisis leading to backward steps in the enjoyment of rights. However, countries are under an obligation to seek to limit as far as possible any retrogressive steps and to muster resources to prevent or limit that and to avoid discrimination in any crisis measures. It's also possible to impose certain limitations. So, for example, in non-crisis times, the question of criteria for access to acute medical care, including intensive care, might be seen as a potential example of a permissible limitation, certainly one that's given rise to concerns about discrimination on the grounds of age and disability. Finally, it's encouraging to hear that the ACT government is exploring the inclusion of the right to a healthy environment in the ACT Human Rights Act. That right is part of, and indeed it goes beyond, the right to health, but it doesn't include all of what is covered by the right to health. Now would be a good time to go further if one is pushing ahead with a new right which has important health ramifications. The experience of the ACT Human Rights Act and other similar statutes has shown that the use of an explicit human rights framework can enhance the quality of policy making and service delivery and enhance public accountability. And it seems to me that it will be timely to add the right to health to the two existing economic and social rights in the Human Rights Act, namely aspects of the right to education and rights to and in work. That would go one step further towards realising the recommendations of the ACT Consultative Committee on a Bill of Rights that made such a recommendation almost 20 years ago. Thank you.
Much, Andrew, for your very wise and learned words. I love hearing that it's timely to the right to health and also the needs for a remedies mechanism. We've long advocated for having human rights complaints similar to the discrimination ones that Karen handles. I'd now like to introduce our three panel members: Emma Campbell, CEO of ATCOS, Karl Briscoe, CEO of NATSIWA, and Darlene Cox, Executive Director of Healthcare Consumers Association. And I'd like to remind participants there is a Q&A function. It's on the bottom right-hand side of your screen. Please give us questions. We're happy to put them to the panelists, but we've got a few that Karen and I are going to ask. First one I'm going to ask everyone to answer, and that is, what can be done to combat the health inequities we've been seeing amplified by COVID, such as race and gender? And what lessons can we learn about how to provide equitable care for all? And what are your recommendations for a sustainable health response into the future? So first to you, Emma, if that's okay.
Yeah, thank you very much, and thank you for the invitation. It perhaps doesn't surprise you, given that ATCOS focuses particularly on people on low incomes, that one of the areas where we have grave concerns with regards equity and access to health is the cost of healthcare in Australia. And what has been very interesting during COVID-19 has been the impact of the increased level of the job seeker payment as a result of the COVID-19 supplement. And it's been an interesting time because many of the people that ATCOS and ACOS advocate on behalf of have seen some better outcomes because for the first time in a long time, they've had enough money to cover the basics, including healthcare. It was an extraordinary shock to me when I first started working in the community sector in Australia to hear how many people were sacrificing basic healthcare because they could not afford it. And the stories that I was hearing were not dissimilar to the stories from countries that I had worked in with Doctors Without Borders. For example, Sierra Leone, Syria, Eswatini, Lebanon, people choosing not to get healthcare or unable to access healthcare because they simply could not afford it. It's often invisible in Canberra because we have the highest median income in any jurisdiction. And because of that, and because so many of us can afford to access decent healthcare, it's not a mainstream conversation often in the political debate here. So I think it's really, COVID-19 has shown us and reminded us of the importance of ensuring that healthcare is affordable. And we need to look at ways that we can protect those on the lowest incomes and ensure that they can access healthcare through, for example, targeted concessions, strengthening our public system, understanding that our health system is not universal, and educating those who can afford it of the struggles of those who can't, so that access to healthcare becomes a key issue in elections and other political debates.
Thanks, Emma. Over to you, Karl.
Yeah, thank you. I would just like to acknowledge the traditional owners and Ngunnawal people before I start, and pay my respects to elders past, present and emerging, and to Selena for her beautiful welcome to country. So I think it, very much from the outset, it highlighted that at the beginning of COVID-19, the pandemic, we witnessed, which was really an attack on the human race of this outbreak. From the outset of the pandemic, we saw responses from Aboriginal and Torres Strait Islander leaders in stepping up and ensuring that our most vulnerable populations of Aboriginal and Torres Strait Islander people were protected. Today, there are no recorded deaths of Aboriginal and Torres Strait Islander people due to COVID-19. And also the establishment, I think, was quite beneficial of the Aboriginal and Torres Strait Islander COVID-19 advisory group. This provided an escalation pathway to enable Aboriginal and Torres Strait Islander expertise to be heard and enacted upon. I think, for the future, I believe that future responses need to recognise that Aboriginal and Torres Strait Islander people have a cultural intellect that cannot be replicated by other services. And listening to Aboriginal and Torres Strait Islander people is proven to be a success, with no lives lost to the pandemic. The inclusion of Aboriginal and Torres Strait Islander people's expertise in the future should be a prerequisite for the protection of our world's longest living culture. So thank you.
Thank you, Karl. Over to you, Darlene.
Yeah, hi. Thanks for the opportunity to participate. Nothing like an easy question first. Thanks, Helen.
Sorry.
Look, a few thoughts around this. I think first and foremost, it actually brought to the fore how important it is to have the voices of the most affected involved in decision making. And I don't think we always did that as well as we could. So people are talking about, yes, we've got a pandemic. Let's now prepare for the next one. So let's make sure that we have systems in place so that there's adequate consultation with the people who are most affected. It underscored the importance of making decisions with consumers and carers. And I think that, telehealth is an example of that, where we all thought that would be a very good idea for many people, but at the same time, you've got to recognise who misses out and who can't access the care if they don't have access to the equipment needed. Now, this government, the last government actually did some funding of community organisations to support consumers, more vulnerable consumers, to try and access and use telehealth to access the care they needed. It also provided us with an opportunity to think a little bit more about that catch-all phrase of those, vulnerable communities. People who have heard me speak before, they know that I sort of shake my head because often we don't actually unpack who we're talking about. It's a more nuanced understanding. It's not just those people, it's people whose life circumstances have put them at risk of poor health. And when we're talking about healthcare, that's what we're thinking about. So it's really important that we think about our NGOs, our non-government organisations, our consumer groups who are well connected to these populations so that we can make sure their views and their perspectives, preferences and needs are well identified to inform any response. We did see an increased risk of violence, and there was all sorts of things that we actually missed because perhaps kids weren't at school, people weren't in the workplace, and so people became more vulnerable than perhaps they were before the pandemic. So I was very interested in how our human services, whether that's the educators, the teachers, the health professionals, care and protection workers, were actually changing their practice to support people, to recognise what the signs were, be more open to some sort of disclosure so they could provide people with the support they needed. People, Emma's already touched on this, but, people not accessing healthcare was an issue, while JobSeeker and the other COVID payments actually enabled people for the first time in many years to fill all of their scripts and see the doctors they needed to get the imaging they needed. There were others who were quite concerned and misread the information coming from health services about only come if it's urgent, and so didn't do their screening or didn't go and see the GP about some signs or deterioration in their healthcare. And I think it's really important now that we get some public health messaging out there to encourage people to access care so that they don't actually miss a diagnosis. There's no delay to diagnosis. They can get the care they need. One last thing, I suppose, was something that was quite interesting to me. One of our members, so Healthcare Consumers Association is a consumer organisation made up of lots of individual members and organisations. One of the women who's a member of ours has more than 7 chronic conditions. And we would check in with quite a number of our older and more isolated members. And talking to her, she said, I've never been healthier. COVID's been great for me. I've not gone out. I've been home. I'm fine. I'm not sick. Hardly had to see my GP. And she said the best thing of all, everyone's remembered that they need to wash their hands and they're better about using their hankies and their tissues. And so actually one of the things it has done for us is it's underscored that critical public health messaging and reminded people that we can get sick. We are fragile and we do actually need to take responsibility for our personal hygiene because it has an impact on others. So that's me. Thanks.
Thanks, Darlene. Over to you, Andrew.
Yep. Look, thanks. I guess the obvious response, and we've done some of the data, but I think there's going to be more data emerging about what has happened, and we'll need to pick that up and require to review and revise policies and approaches, ideally from a human rights perspective, and as I think it was said, in collaboration with the groups whose rights are actually affected. There was a certain amount of that which didn't happen. I think the extraordinary thing about the pandemic has been, certainly at the federal government level, but also at the state government level, the enormous work that they have done and the funds that they've found to enhance economic and social rights, with all the shortfalls. But equally striking has been their almost total failure to talk about it in terms of economic and social rights. JobKeeper or JobSeeker, the increase has not been described in terms of actually living up to the obligation to provide adequate social security or an adequate standard of living. Ditto with JobKeeper. And yet, the work around putting people who were homeless into hotels during the pandemic, but then essentially leaving many of them to fend for themselves afterwards in Melbourne. It's another example really of an attempt to address homelessness partially. So I think it's the ongoing challenge we face. How do we get our governments to talk more about rights, in particular economic and social rights, when they are doing things which are central to the achievement of them and should be clearly informed by it. And I think the big difference, and we'll see some of it hopefully, is between the two of the Royal Commissions we've got going. The Aged Care Royal Commission, which hasn't done very well in terms of an explicit rights framework. It doesn't have a doesn't have a treaty to guide it, and I think it's very ad hoc compared with the Royal Commission on Violence, Abuse and Exploitation of Persons with Disabilities, in which rights are at front and centre because of the convention. And I think we need to think about how we get those rights frameworks into the different sorts of bodies and into policy making, and in reviewing the development of the COVID response, because we still got a long way to go economically in terms of adjusting that, and rights may be useful to try and get into that question.
Thanks, Andrew. Darlene, one of the more controversial things that emerged during COVID was an issue around access to health resources and health services. How do you think triage decisions should be made? And is it important to develop ethical decision-making frameworks with community input to determine priorities for the allocation of those resources, particularly in times when resources are scarce as they are during the pandemic?
Yeah, this was probably the toughest thing that I dealt with this year. And I know my colleague Emma was also involved in some of these discussions, as was Helen. Look, we can't ration healthcare based on gender, race, sexuality, citizenship, where you were born, who you love, none of that. There is absolutely no room for discrimination when making these decisions. It can't be about people's physical status or mental disability. We put that to the side. And in working with the ACT Chief Health Officer in developing an ethical framework, that was one thing that came through very, very loud and clear. And there was involvement of people with disabilities, older people, people who are accessing palliative care services at that time to develop it. It's really hard to make good policy in a crisis on the run when you're dealing with incredibly difficult issues like this. The Minister said it earlier, around fast decisions have to be taken. And I appreciated that because I think how many decisions were being taken on a daily basis by people who had access to the information about the projections around what was going to happen. It was tough. So we absolutely can't discriminate. We also can't make judgments about someone's life and the quality of life. And that's something that came through very strongly. You can't determine or make assumptions about who's going to have a greater quality of life of someone else. So if you've got one, a finite resource, who gets it? And you can't make the decision on that. Proper consultation. Look, I think we did the best we could at the time. We made sure we got as many people involved, as many people who were affected in those perspectives there to provide advice. Ultimately, the advice went in and it was finalised through the Health Directorate. I would like very much for us, once we get a vaccination program in place, for us to stop and reflect on the process, but also the outcome. One of the things that I'm interested in, well, from a healthcare consumers perspective, our executive committee met last night and we were talking about the ethical framework, the fact that it has been signed off, but it's not been made public. The decision's been taken by the government that it won't actually be made public until it's activated. Now, this is not something that we support as an organisation because I think transparency around these decisions is absolutely critical and we need to use it as an opportunity to talk to people. One of the arguments we had used is if we could talk to people about an ethical framework around having to make those hard decisions with finite resources, it might actually motivate people to do the right thing and comply with the public health announcements. But the principle of transparency, I think that we've got to continue to advocate for that document to be released so that we can get a little bit of transparency, but also scrutiny and can reflect on it to see how can we improve it? How can we talk to communities about this really difficult issue? We also talked about a lot around end-of-life care. With the requirements around COVID, because it's such an infectious disease, we, at the end of life, if someone was really unwell, the families can't be there. So one of the things we were strong about was how are we going to make sure family and friends are involved in some sort of end-of-life decision, And if you can't be there in person, how are we going to support some opportunity for people to be able to say goodbye? I felt strongly, personally, very strongly, that if we had an opportunity to reduce trauma, we should actually take that. And we didn't want people having traumatic ends of life and losing loved ones. We wanted to be able to provide people with a good death if that was what was going to be needed. So it was, yeah, they're my thoughts, Karen.
No, I appreciate that. And I think, as you say, even the decision to release that document shouldn't be done at a time of urgency. It needs to be done in a considered way.
If I can just add to that, because I mean, ACCOS did a lot of advocacy on this, particularly with my colleague Craig Wallace, who's very well-known advocate in disability policy. Had we not had a Human Rights Act in the ACT, I worry that there would not have been the urgency around this, and perhaps the ethical framework that we haven't seen yet may not have been so ethical. So I think it's really important to explain to people the power of human rights legislation to actually get these kinds of protections in place. And perhaps if we had a right to health in the ACT, we would have had these kinds of protections around access to resources and around triage decisions before we got to a situation like COVID-19 and we were facing some really terrifying situations. I also want to point out just how traumatic some of the discussions that were taking place were for people with disability when people were discussing the value of life, the value of people's lives for older people and people with disability. And had we had these protections in place previously as a result of strong human rights legislation, including the right to health, many people may not have had to have been exposed to such traumatic discussions and conversations.
Thanks, Emma. Very interesting that 75% of the deaths in Australia from COVID have been in residential aged care. So that shows where there's a big fault line. I just wanted to ask Karl about why it's important to have culturally appropriate health services. How can we ensure that the needs and experience of specific groups are fully addressed in designing our health responses?
Yeah. Okay. I think, from the beginning, when health services aren't culturally safe for Aboriginal and Torres Strait Islander people, why would we want to access them? We do see a large number of potentially preventable hospitalizations, because health services aren't culturally safe and responsive to our own worldviews, which would allow, if they would allow the health needs of our people to be better addressed, especially in accessing preventable healthcare services rather than our people, coming in at an acute stage. I suppose some recent examples of designing health responses, the co-design of the latest Closing the Gap National Agreement, which involved the coalition of peak members and government, so 52 organisations worked with government, not only to set targets, it was also identified priority reform areas which we believe will have greater impact in addressing the social and cultural determinants of health on overcoming disadvantage faced by Aboriginal and Torres Strait Islander people. Also, we have observed earlier this year APRA, so the Australian Health Practitioner Regulation Agency, the launch of their cultural safety strategy. What they adopted, the definition that they adopted was cultural safety is determined by Aboriginal, Torres Strait Islander individuals, families and communities, as well as health professionals undertaking a critical self-reflection on their own biases and beliefs. So I think if health services are to be culturally safe and responsive to the health needs of Aboriginal and Torres Strait Islander people, it's essential for health services to involve Aboriginal and Torres Strait Islander people in the design and delivery of making health services culturally safe and responsive to the health and well-being of our people. Thank you.
Thanks, Karl. The Human Rights Commission also has a cultural safety charter that we launched in September last year, and it was based on healthcare workers. So it's great to see it being rolled out by AHPRA and more broadly.
So Emma, just going back to your earlier point about people with a disability, and I noticed that Eliza has jumped onto the chat to raise this issue. What do you see are the barriers faced by people with a disability when accessing the health system? And what's your view about what happened in that space during the pandemic? And I think, as Helen referred to, what were the fault lines that emerged during those discussions about triage and ethical decision-making and access to health services?
Thank you. I mean, again, I want to acknowledge Craig for his information and support in preparing to answer this question, though I take responsibility for how I deliver it. But look, we know that people with disability have poorer rates of health in the ACT and much more frequent comorbidities as compared with the general population. And too often, these outcomes are for reasons completely unrelated to the disability itself, but they instead relate to systemic and sometimes direct discrimination experienced by people with disability. The ACT Council of Social Service last year published a report called Imagining Better, which reflected on access and choice and control in the ACT Health Service for people with disability. And it highlighted a number of challenges in the health system that lead to these poor outcomes. They included economic disadvantage, diagnostic overshadowing, which is where a person's disability is treated as the problem rather than the person's presenting medical condition. It highlighted poor attitudes, including a lack of a social model for responding to disability or health within the clinical setting. It highlighted inappropriate digital and physical infrastructure that led to access barriers and poor communications. And it highlighted serious service gaps, including a lack of tailored services to help manage diagnostic conditions and to understand, treat and manage both the primary and secondary health impacts of different kinds of disabilities. Among the people we spoke to, nearly all of them identified socioeconomic disadvantage as a direct personal barrier to their enjoyment of health on an equal basis with others. Sometimes it was because they just couldn't afford outright the health services that they needed to access. But sometimes the barriers were more subtle. They couldn't afford the travel to get to the health service or the time off work needed to maintain a healthy lifestyle or to access food for a healthy diet. They also talked about a medical model of disability, which assumes that the person with disability is the problem rather than the environment in which they are living. And that included the clinical settings that they were in, which were often described as inaccessible, both in their built form, but also culturally. Extraordinarily, many said that there are fewer disability supports in the hospitals than in their own home, and they were often unable to bring carers or the equipment they needed to be able to have the care that they required in primary and tertiary health settings. And this was then worsened by the attitudes where some practitioners lacked basic skills to interact with people with disability. They were ignored. There was no effort to build rapport. And often, or nearly always, the person with disability has a deep understanding of their need and could work with the health practitioner to achieve good outcomes, but only if they're respected and listened to. There are major service gaps in both specialist and wraparound supports from services, and a lack of practitioners who have a comprehensive understanding of a person's core condition. And these specialists are not available when people are accessing healthcare, including when they're in tertiary services such as hospitals. They're sometimes not even available locally, forcing people with disability to travel interstate to get the basic healthcare that they deserve. There were good examples, or examples of good practice, and the common theme throughout all of those examples were respect and a willingness to listen to the person with disability. And those examples showed were situations where practitioners had valued and acted on patient feedback, and where health professionals had taken time to gain an understanding of people's experience. But there was little example of good practice around built infrastructure and systemic change, too often relying on the attitudes of an individual practitioner. And I think it's those experiences that created so much fear and trauma for people with disability during the COVID-19 pandemic. The fear that on top of those normal situations of experiencing disadvantage and discrimination in the health system, when choices were being made in a heavily stressed and heavily resource constrained system, people with disability were going to be the ones that were left behind. And that was shown time and time again in the response. People with disability lost access to basic goods and services. There was no access to PPE for months. And the difference in response to people with disability compared to aged care settings was quite extraordinary at times. Whilst recognising the high levels of risk of people in aged care settings, particularly congregate settings, but there were many examples of people with disability also in those high-risk settings, and their needs were not responded to. And the response was slow. And this has been criticised by the Royal Commission, not only by organisations in the ACT. And I think also people with disability were missed out. For example, there was no stimulus given to people on DSP, despite the increases in costs for many people with disability in accessing healthcare. And they were also left out of the job maker subsidies, which could have supported them into open employment. And lastly, I just want to reiterate the sense of stigmatization and trauma that many people have been left with as a result of COVID-19 because of the language and discussions that have taken place around the value of people with disability. And I think this is something that is going to take a very long time to rebuild, so that people with disability once again have trust in all of our systems, including the health system. And the protection of rights in legislation is one critical way we can rebuild that trust.
Emma, can I just ask, you've prompted a flurry of comments here. Can I just ask, one of the questions that's been raised is, should we resolve these issues before we progress something like voluntary assisted dying to make sure that people are safe in the health system and in accessing health services before we progress legislation or try and progress legislation around voluntary assisted dying? Do you have a view on that?
Look, these kinds of either-or questions are incredibly challenging, but I think when you look at the numbers of people in the ACT and the intersections of vulnerability and disadvantage that come with that are attached to people with disabilities. So high numbers of Aboriginal and Torres Strait Islander people who are also people with disability. 50% on average of our prison population are people with disability. Incredibly complex disadvantage that if we do not work immediately to protect, we continue to risk creating communities in what is an incredibly wealthy and successful jurisdiction that are absolutely and totally excluded from accessing basic services. And given the fear and the impact that we've seen during COVID-19 on people with disability and those cross-sectional vulnerabilities, it must be a priority. And that's why we've been calling, for example, for a disability health strategy. And we would say that that is something really urgently needed in the ACT.
Darlene, did you have any comments on that? I noticed your vigorous nodding.
Yeah, well, the disability health strategy is absolutely one of the ways that we can address this. And I know that in the election campaign, all parties actually supported the call for a disability health strategy. It's in the parliamentary governing agreement. So let's progress that. One of the other things I think is that we've got to remember that we actually had a few accessibility wins around this too, and telehealth again is one of those. For many people, telehealth with their regular GP or being able to access their psychiatrist or psychologist in a safe way, if they had the equipment to do so, is something that we can't roll back. You know, it was very disruptive at the time, but it's really made a difference for many of us. One of the things that we note is that slowly people are starting to revert to face-to-face for consultations, but we want to maintain the pressure on the health system and the challenge to the health system to continue telehealth, whether it's general practitioners who mostly use the telephone, but let's try and get them using a video interface. And also for outpatients appointments, let's try and get them continuing to give consumers options, whether we want face-to-face, whether we want a telephone conversation, or whether we want a video conversation. I think we can embrace some of the disruption that COVID has presented us in the health system for good, and actually will address some of the accessibility issues that we all experience.
And I think working from home is also a huge issue for people with disabilities, that those options suddenly appeared after years of saying it was too hard for managers. So things can be done with the right will. In terms of vaccines, we know that the government has put aside money for 10 million vaccine to purchase. I want to ask Andrew, what are the human rights implications of availability and affordability? The government said it will target residents of aged care and healthcare workers and workers in aged care. And also, is it compatible to have compulsory vaccination policy, such as Qantas has announced that will be a criteria for international flights, but might we see that in schools and workplaces and hospitals, and what are the human rights implications of that?
Let me start perhaps on the general issue. I mean, the whole question of vaccines, I guess, is still a little bit up in the air, in that we have orders in for a whole range of vaccines, some of which have yet to be certified. You know, so the questions of
certified today.
Right, but the questions of availability, what comes, its safety, and so on. A number of issues, though, I suppose. One is the question of safety, and the vaccine policy that the government released in August 2020, I think it was. I'm not sure whether that's still the latest thinking. Obviously stressed safety, and that issue of safety, would I imagine, it's obviously part of the right to health, is going to be an ongoing issue. They'll have to be monitoring what comes out, and as they've said, we have the luxury of a little bit more lead time than some other countries. So that's going to be obviously critical. The availability issue, I didn't mention in my talk the 3A's Q framework of the Committee on Economic, Social, Cultural Rights and the right to health. Things have got to be available, accessible, what else? Available, accessible, appropriate, and quality. And availability, part of that is cost. And we're in the fortunate position, as I understand it, that as a rich country, the government is proposing to fund the rollout of the vaccine for everyone in Australia. So that doesn't seem to be a major issue here, depending on where the money comes from. The criteria, as you've mentioned, the good thing, I guess, is that there has been the indication of those in the vaccination policy, the transparency and opportunity for public discussion, which I think is critically important, and this is in other areas. Although I see that there has been some discussion in some of the media today about the priority that should be given in it was in Australia or elsewhere to people who are in detention, whether in prisons or in immigration detention, who might be particularly vulnerable. So I think there's still maybe some debate over that, although the broad outlines seem to be the subject of a large degree of consensus, although of course then the other issue of acceptability, cultural acceptability, is going to have to be addressed very sensitively, I imagine, not just amongst them and with Indigenous communities, but other culturally and linguistically diverse communities in Australia. If we go down that route, is it going to be? I understand it's not going to be compulsory. The government is still hoping, I think, to go voluntary. So we don't necessarily have the issue of limitations on Qantas's approach. I'm not sure there's a clear answer there. Obviously, they could say, if there's evidence for it, that there are safety concerns for passengers, and this is the best way to ensure that. I think at this stage, I think it's largely theoretical, and I think we won't really know till we're closer to the event. And of course, there may be some people who need to travel who may, for whatever reason, not be in a position to take one or other of the vaccines, and then we'll have that issue, I guess. I don't have a straight answer to that one, I'm afraid, Helen.
Thanks, Andrew. We've had
just wondering, Karen, just following on from vaccines, I think there's also an opportunity. Certainly, it doesn't seem like we're clear on the rollout strategy in Australia. And at the moment, it's the federal government that seems to be driving that, although clearly the chief health officers have a role. But I do think that we need to be thinking about the role of general practice, whether they can take a role in inoculating populations, but also NGOs, non-government organisations who work with particular cohorts, groups of people who may be vulnerable and at risk of really poor outcomes if they contract COVID. So how are we going to make sure that we have a whole of health system approach to this, which includes non-government organisations? Thank you.
Particularly hard to reach populations like homeless people would be a prime example.
I think it would be amiss if I just didn't mention the comment from my colleague Craig Wallace in the chat. And he says that we need to support people with disabilities to live with dignity before we have policy discussions about rights to exit with dignity. Discussions are incredibly stigmatizing in the context of COVID-19. And we've had a year of people debating the value and relative merits of our lives being people with disability. And I think it's a really important statement to share with people who are listening in case they're not able to read that in the chat.
Thanks, Emma. We've had a question around how can a human rights framework and the right to health improve end-of-life treatment and palliative care options. I might jump in on this one if nobody objects. The Minister started the discussion with concerns about the ACT not being able to progress legislation to allow voluntary assisted dying, even though it currently exists in Victoria and WA, and there is momentum around it interstate. The right to palliative care is part of the right to health. The right to die with dignity, sparing people avoidable pain, and enabling them to die comfortably is an essential component of palliative care and the right to health, and clearly a basic human right. This means a clear understanding of the difference between palliative care, palliative sedation, and assisted dying. This is not a theoretical problem. Sorry, you can hear I've got a little bit of passion around this one. We have seen cases in the ACT where there have been experiences of serious physical and psychological distress at end of life because of hesitancy around the use of palliative sedation. It means here in the ACT that providers who have public authority obligations must ensure that they are taking steps to ensure that people have access to adequate medication and treatment and are not dying in situations of unnecessary pain or distress, which is also clearly experienced by their families and carers. Applying public authority obligations should ensure there is no opportunity for people working in this space to conscientiously object to providing treatments that are entirely lawful and designed to ensure people are comfortable at the time of death and that their friends, family and carers do not have the added burden of knowing that their loved one died in pain or in psychological distress, particularly knowing that their death was imminent. In a country that's invested heavily in public-private partnerships, the right to health would also ensure that human rights obligations of our public healthcare providers extend to those organisations that are providing services on behalf of government. The right to die without cruel or inhumane treatment, in pain or in psychological distress that could be alleviated with the right medications, is a right we should be insisting on. And you can obviously hear I'm very passionate about this, but I'm happy to hear from anybody else on the panel.
I agree with you completely, Karen. Palliative sedation is one of those things we need to talk about more when we talk about end of life and how we provide treatment and care to people, families, recognising people in place. One of the things, having had this experience recently with a dear friend, you know, when we did talk about palliative sedation, we were told, oh no, we're not there yet. Well, it seemed to me that probably we needed to have the conversation about absolutely using that. So it's about health literacy. It's about people understanding the system, understanding their rights, understanding and feeling confident to be able to ask about it. But many people would not even know that palliative sedation, what it is, and why it would make a difference in supporting people to have a good death.
So I
just see that Craig said that people with disabilities must be involved in these discussions. Absolutely, Craig. I agree with you. People, consumers, carers, older people, people who are living with disability, disadvantage of any kind, we absolutely must all be part of this.
And I guess just picking up on that, have responses to the pandemic adequately protected the human rights of older people, including their right to health? I'd be interested in people's views on that. And I guess also views about gaps in existing protections. Darlene, I might start with you.
Yeah, there's been a strong focus on residential aged care, but I think we've been pretty slow to act in Australia on that, finally getting our act together on it. But still, all of those people who are living, who are maybe older and live at home, who are inviting people into their homes to provide support for them, they may have stopped it. PPE was an issue, Emma's already mentioned that, in rolling out to community organisations, which then put at risk many, many people. And they had to then make decisions about whether they were going to invite people into their homes and take the risk that they may in fact be exposed to the infection. So I don't think we handled it well, but we've got to, I would hope in 2021 we can take the time to sit back and have some talks about what didn't we do right? What did we do right? Because if you talk to any infectious disease specialist, they're talking about there will be another pandemic. So let's make sure that we're ahead of the wave and we know how we've learnt from this experience. We value people, we put people first, and we make sure people are treated with dignity and respect and get the support they need.
This is an interesting question because, again, it highlights the interaction of rights. Given the statistics and the number of older people who died as a result of COVID-19, obviously we were not able to protect them as much as we should have. And one of the areas it interacts with is the right to work and the right to be protected in the employment space, and the terrible situation often faced by many workers in the aged care area who are in precarious work, have to have many different jobs in order to sustain their family and get a decent income. So you see the interaction of rights, of systems that result in these very challenging outcomes. And that is why I think APCOS today, for example, put out a media release calling for all ESC rights to be enacted, because they cannot exist, individual rights cannot be achieved without all of the rights being realised and achieved.
Karl, can I just ask if you had any thoughts on this issue around the rights of older people, particularly in the Aboriginal community?
Yeah, I think, just looking at the pandemic and seeing the response that we had from our Aboriginal and Torres Strait Islander leaders, that really did protect our vulnerable populations, especially our elders and elderly within our community. Hence why we haven't seen any deaths in Aboriginal and Torres Strait Islander people from COVID-19. So I think there's some valuable lessons that could be learnt from this, and looking at replicating it, especially around the vulnerable elderly population during times of pandemics, to really take the front foot and get on the front foot if there is another one to occur. There is some valuable lessons that could be learned and implemented if there is another wave or a pandemic.
Pat Turner said something that from Nacho, that talked about the elders of the Aboriginal and Torres Strait Islander community being the university of the community, and the extraordinary success in protecting elders is something that I think has to be acknowledged and recognised, and something that we all must learn from. It is a success of the Aboriginal and Torres Strait Islander community. Just one other point with older people is the balance of risk. And whilst we must absolutely protect older people particularly in congregate living settings, one of the things that we've seen since is the tremendous isolation and loneliness of many older people in those congregate living settings, because the operators are now so fearful of the implications of opening up. Older people cannot engage with their families or their friends or in normal social activities. And that's particularly a problem for people of culturally and linguistically diverse backgrounds who may not have anyone to speak to in their language if they are cut off from engagement with family and other community members.
Yeah, Emma, that was an area that we got a number of complaints to do with aged care during COVID, and particularly, I guess, that notion of, in eliminating risk, the operators, in fact, had a very negative impact on people's well-being, as you've said. And I mean, some of the circumstances we had where people whose family members breached particular, strategies that the operator had put in place and were then banned for 3 or 4 weeks at a time, which had an extraordinary impact, both on the well-being, but also the physical health of people who are so dependent on family members and carers to come and, feed them and keep them well. So I think it's been a real revelation in terms of, how much control we have in those closed spaces during periods like this. Sorry, Helen,
Did Andrew want to say something?
Andrew? Yeah, please.
Look, can I just say 2 things? One is in relation to the really important and impressive experience of the Aboriginal community in terms of elders and so on, but and that stands there, I think, is a very important lesson. But also did want to mention that within the broader community, there were examples of intergenerational solidarity, of businesses endeavouring to overcome isolation and so on. I think we need to think about those and build them into part of the practice. You know, I'm not sure it was entirely successful, some of the early morning supermarket rushes for older people, but you know, younger generations not undertaking their social life in order to protect their parents and grands. So there's a range of forms of solidarity we should not let go. And the counterbalance to that, just as in relation to persons with disabilities that Craig and Emma have been stressing, it's not an isolated problem, it's a broader issue that we're addressing, is the ageism that did come out in the context of a whole range of discussions, restrictions, and so on. You know, everything from the boomer remover at the ugly end through to the more beneficial protective end. And I think that some of the issues, particularly the Royal Commission and so on, we need to think about them more broadly in terms of older persons' rights more generally, and how ageism influenced the structures that led to those particular impacts. So I think we have a job to do there as well, notwithstanding the protections against discrimination in services on the grounds of age around Australia. Thanks.
And just a final question to all members of the panel. The 2020 bushfires highlighted concerns about sustainability and the impact of climate change on health, particularly smoke inhalation. As we said earlier, the parliamentary agreement has committed the government to consider introducing the right to a healthy environment. Just wondering how we think the right to health can help inform policies to address climate change. Emma, would you like to go first?
This goes back to, I think, the argument that I've been making, ACOS has been making for some time, that human rights are universal, indivisible, interdependent, and interrelated. You cannot have the right to health if you don't also enact a right to a healthy environment. You cannot enact a right to a healthy environment if you don't also enact a right to housing. How do you safeguard an individual's right to education if you're not safeguarding their right to physical and mental health? So I find the individual discussions about rights very challenging and frustrating. Obviously, in this context where we're talking about the individual experiences in the health system, it's very powerful. But when we're talking about the vision of the ACT as a human rights jurisdiction that achieves protections for our most vulnerable and for our disadvantage and for those who face disadvantage, the separation of these rights is counterproductive to what we are trying to do as a progressive jurisdiction and the first jurisdiction that enacted a Human Rights Act.
Darlene.
Climate change and addressing climate change is the main game. If we don't have a healthy planet, we do not experience good health. Simple as that. Has an impact on infrastructure, whether it's the houses that we build in, what we live in, and many people on lower incomes may not have the adequate insulation, so they're living in hot boxes in summer and ice chillers in winter. We have to do something about that. We have to make sure that people who are at risk of homelessness or experiencing homelessness actually have somewhere safe to live, because the extreme temperatures are only going to increase, and that has a significant impact on their health. I think we've got opportunities with the design of health services to make sure models of care reflect on that. Any health service planning going forward has to think about increased temperatures so that more people are going to present with heat stroke. What are we going to do about that? Let's make sure that infrastructure, let's have covered walkways at hospitals and health services. Let's just think about how we can make hospital and health service campuses as livable as possible on the outside as well as the inside. But I think it does actually require connected solutions. You can't think of it in isolation. Thanks.
Thanks, Darlene. Over to you, Karl.
Yeah, I suppose, like, we all know that, you know, the right to health is a basic human right. You know, we've seen and witnessed the devastations of the bushfires to the environment and, you know, the effects on our health. I really do believe that there's a need to really and truly deeply embrace Aboriginal and Torres Strait Islander traditional knowledge into environmental policy management. With examples of the coal burnings we've heard of, you know, is very much a starting point. And, you know, I do acknowledge the ACT Human Rights Cultural Safety Charter. You know, the values are in there around respect, collaboration, integrity, accessibility and courage. You know, I think that the ACT has a brilliant opportunity now, you know, to embrace Indigenous cultural knowledge around traditional fire management. And we won't see the devastation that we saw, you know, late last year, earlier this year. Thank you.
Thanks so much, Karl. And lastly, over to you, Andrew.
Look, I agree with what has been said about the need for the desirability of a holistic solution. And I guess that's what we've been saying for 20 years and haven't yet had success with the government. I mean, I never thought to see the day where rights to work and in work would actually make it in. It's there. And I suppose a pragmatic strategy. And, you know, has the dam broken so that we could now go forward and say, no, and another one, just adding them one by one now just doesn't make sense. It's clear they don't destroy the joint, that they are helpful, that they've improved policy. Why don't we now move to introduce the other ones given their interrelatedness? We've got some and not all. That's, I guess, a political assessment on the ground. It's not either or. I mean, we can continue to try and bring rights analysis into other policy areas and to keep it there and to strengthen that. And I suppose at the end of the day, we're going to be asked the question by government and others, you know, what difference does it make to actually have it here in this particular piece of legislation? And I think we're going to have to show. And I think one of the things that, if it hasn't already been done by the Commission, here's some work for you, it might be to pull together the real range of insights and analysis today within a right to work framework, and try and pull together and show how, if we'd had a unified holistic right to work analysis, it might have helped us avoid some of these issues, and will certainly help us do it better next time, whatever the future has to throw at us. Thanks.
I think talking about rights is incredibly important. We did have a Prime Minister, Conservative one, who called human rights communism. So it's good to hear it's even being used in Bunnings by Karens, and Karen, it's been a close.
Had to get the Karen comment in there somewhere. Sorry. That seems like a good note to finish on. Thank you, everybody, so much for your contributions today. It's been a really, you know, fruitful discussion. Given the parliamentary agreement, it also means that we've got a platform to take this work forward. So we look forward to working with you into the future. Thanks, everybody online, for coming along. Thank you also to the Human Rights Commission team who put this together. Obviously, Helen and I have just fronted up, but there's a whole bunch of work that went on in the background. So I just want to thank those guys as well. And that's a wrap, dead on time. And have a great afternoon. And again, we look forward to working with you on these issues into the future. Thanks a lot.
Thank
Bye,
you.
everyone. Thank you.
Bye.